Okay, so here's the recording for diabetes mellitus that I wanted to make sure I get covered so you guys will understand a little bit better about maybe some diabetes. Okay, first of all, diabetes mellitus, if you think about it, there's kind of sort of three types. You have a type 1, which is your insulin dependent. They used to call it juvenile onset, but it's insulin dependent. They don't take any type of oral hypoglycemics. It's all insulin. Type 2 is more about insulin resistance, and that's more about the body not being able to handle the additional weight of the person, or they have insulin resistance. That's type 2. Typically it comes later in life, but not necessarily. We are seeing it come in younger people, even in their teenage years. So we're starting to see that. And then we have gestational diabetes. So it's going to be even more complicated if you have a patient that has type 1, and then they're going to be dealing with the whole diabetes completely through it. It's not really gestational diabetes anymore. It's just still type 1. So type 1, we already know type 1. We've already talked about all of that. So pre-gestational diabetes, this would be a patient that does not have any history of diabetes at all. So, or they have a history of, they're kind of like a pre-diabetic. Their blood sugars have been a little bit high. They might have a little bit of type 2, but we haven't really developed anything yet. We know in the past we didn't really have the ability we didn't really understand how to monitor these moms. We really didn't know what was going on with them. So a lot of women that had any type of diabetes back and they were having children, they had a poorer outcome. Now with all the new technologies we have, all the new testing, all of the new fetal surveillance, all of the things that we have available to us now, our babies and moms have a much better outcome because we know a little bit better how to treat them. But the one thing we do know, in any mom that has a glucose problem, if she's poorly controlled and we have poor glycemic control, this baby is going to be at high risk for birth defects, stillborn, hypertension, polyhydramnios, which just means they have a large amount of amniotic fluid, preterm delivery, and macrosomia, which means the babies are going to be very large. So just talking about diabetes mellitus. So this is just moms who did not have diabetes before. Maybe they had a little, maybe their sugars were a little bit high, or maybe they've never tested them. They never knew. But this is a mom that it occurs during pregnancy only. It's kind of similar to type 2, so they get a little bit of, they have a little bit of insulin resistance there. But one thing that the doctor's going to look at, if you look at these things right here, this is what the doctor's going to look at when they come in for that first prenatal visit. He's going to look at, did they have a history of a large gestational age baby? Did they have gestational diabetes before, or did they have a family history of gestational diabetes? Do they have a family history of diabetes mellitus or type 2? If the maternal age is greater than 35, we know that does put them at increased risk just because it puts strain on that pancreas. Because as we get older, the pancreas, gets tireder, and sometimes that's how we develop that type 2. Obesity. This is for women who are greater than 200 pounds. The body sometimes isn't able to keep up with the demands, especially the high metabolic demands that the mom is requiring now, trying to grow that additional human being. We see it more in non-Caucasian ethnicities. This is where we get a fasting blood sugar that's greater than 140 or random, just at any given time, greater than 200. So a lot of women that develop gestational diabetes, and this is why we didn't really know about it a long time ago, because we really didn't screen for it. We really didn't understand it. So now we screen every female for it between 24 and 20, usually between 20 and 28 weeks. Everybody gets screened for gestational diabetes. That way, the quicker we can come up with it and find it, the better we're going to be able to treat that mom. They're at increased risk for developing type 2 later on in their life. So that's something that they need to be aware of, that once they develop gestational diabetes during pregnancy, they do have a risk of their glucose not going back to normal, or they are at a higher rate, a higher risk 5 to 20 years down the road after they deliver that baby of having a little bit of gestational diabetes. Fetal complications. So I do want you to know, some about the fetal complications, because the fetal complications can be a big deal. We know the maternal complications, but when a baby's born, when it's inside mom, the fetal growth can be a problem. We know that they're macrosomic, so they're going to be much larger than a regular baby. So sometimes they can have placenta issues, and hypoglycemia. As soon as the babies are born, a lot of times they've been used to getting like loaded up with lots and lots of sugar. Well, now they're not going to be getting that much sugar because their sugar train's been cut off. So a lot of these babies are so used to having all that sugar, they develop hypoglycemia after birth. So a lot of times after they're born, we go ahead and test every baby that is a gestational diabetic or a baby delivered by a diabetic mom at delivery. And then, we usually keep a closer eye on those babies. Not that we don't keep a close eye on every baby, but we're going to watch these babies a little bit more for feeding difficulties, shakiness, lethargy, extreme sleepiness, things like that. Because if they get any of those or exhibit any of those signs, we're going to be checking them for hypoglycemia. Sometimes we can have these big old babies, but their lungs aren't mature. So we need to be thinking about that. They are having a mom that had gestational diabetes or diabetes while they were carrying their babies does increase their risk of having some health concerns later in their lives. Cesarean deliveries are not uncommon because the babies are so large. If you look at the greatest risk is macrosomia. That's what that means. Any baby greater than 8.8 pounds is considered a macrosomic baby. But I have also seen babies that are big babies that have been born to moms that don't have gestational diabetes. So sometimes babies are just big, but if they do have gestational diabetes, they're going to be at much greater risk because all that sugar goes to moms and then goes to the babies. The babies get that sugar and they pack on those pounds and they get bigger. Okay, now let's see if I can get this to move. Screening. Every mom's going to get screened, again, between, I think I said 20 to 28 weeks, 24 to 28 weeks gestation. It is positive. It's going to be a positive test if their sugar after that 1 hour of sugar load is greater than 130 or 140 or higher. So if they fail the first one, they have to go back and do another one. And so we're going to tell that mom to fast overnight, no caffeine, no smoking, 12 hours before the test. Then they're going to come in. We're going to load them up with all kinds of glucose, and then we're going to test their glucose at 1, 2, and 3 hours. Their sugar should go down to normal. If they fail this 3-hour glucose test, they are considered to have gestational diabetes. Now, once someone has gestational diabetes or they have type 1 diabetics, sometimes they can go in what we call ketoacidosis. So what happens is if they don't control what they're eating and they're eating way too much sugar and they're not giving themselves insulin or taking the medicine like they need to, then they don't have what we call good glycemic control. So their blood sugar levels are going to stay much, much higher. The higher those levels get, the body starts to get into a metabolic problem. So when the body goes into the metabolic problem, it goes into ketoacidosis. So when the sugar is high, you kind of almost have to have a key to unlock the sugar inside the bloodstream. And once you unlock the sugar pours out of the bloodstream and goes into my cells, and my cells get fed. Well, if we don't have that key, which is our insulin, then we can't unlock it. And so that high glucose just remains floating around in the blood cell. As it gets higher, our body cells are saying, we're starving, we're starving, we're starving. So in a response to that starving, your body will start to break down skeletal muscle. When it starts to break down that muscle, which we do not want it to do, part of that is they give off ketone bodies. And so we start to see ketones in the urine. And we don't want that because that is a good sign that they are breaking down that skeletal muscle. So how do we treat it? The best way to do it is to try to treat it pre-pregnancy. So, we talked, especially your type 1s, because they already have a sugar problem. So they need to talk to their doctor before they become pregnant about, help me get my glucose under control prior to pregnancy. Because we know that first 8 weeks, if mom has a higher blood sugar level, that's going to increase that risk for that baby to have any type of fetal anomalies. And so we want to make sure that that mom gets under good euglycemia, make sure that her sugars are staying good. So we're going to also encourage them to start taking all their prenatal vitamins, all of their stuff ahead of time. Take that folic acid. Get your body ready for that pregnancy so you can give that baby the best chance and the best survival that you can prior to pregnancy. So, treatment of gestational. So how do we treat gestational? Gestational, again, we want that glycemic control, so we're going to make sure that we are testing those moms. We're going to do finger testing. We're going to do hemoglobin A1Cs. Finger testing is ACHS, which means before every meal and at bedtime. And sometimes we will treat that accordingly. If they're type 1 diabetics, they're already going to be used to this insulin. A lot of times your gestational diabetic moms will get a long-acting insulin that just kind of, they usually will take insulin once a day. Not always. Sometimes we will have to give it multiple times a day, but sometimes we'll try to give them one insulin a day and then keep a close eye on their blood sugars. That hemoglobin A1C does tell us the 3-month of how their sugars have been running. But one of the things we want to always look for is hypoglycemia. So especially any patient that is on any type of, especially insulin, but your oral glycemic agents, which you will rarely see us treat gestational, any type of type 2, if they're pregnant, with oral hypoglycemics. The only one that is considered safe in pregnancy is metformin. And honestly, we don't really use that in pregnancy. They want them to go to insulin because we can control it much better with insulin than we can with any type of oral hypoglycemic. So they're going to be giving them the injectable type, which could also cause them to have some hypoglycemia. So we want to watch our moms. We want to watch them for that shakiness, that confusion, cold, clammy skin. They feel like they're going to pass out. Their skin gets pale. All of those kinds of things we want to be watching for. Hypoglycemia is kind of a medical emergency. We have to treat that. Diabetic ketoacidosis, or DKA, that is where this comes on a little bit more slowly. So these moms, it isn't going to be something that within 10 minutes you're going to see, on the opposite of that hypoglycemia. This is something that's going to occur over a few days. So their blood sugar is going to go up till it gets to a certain level, and then they're going to start exhibiting ketonuria. They're going to have those Kussmaul breathing. They might have that fruity breath from those ketone bodies being given off as they breathe and talk. So you may see that. The reason they're going to get ketoacidosis is, one, they're not taking their insulin like they need to, or they're eating too much and the insulin's not able to cover it. So those are two big things that we have to look at. We also have to look at infection. If moms get an infection, we know because of the elevated cortisol levels in the body, that is going to cause hyperglycemia. We also know that tocolytic therapy, which is therapy that stops labor, some moms will go into preterm labor early. That medication will cause them to have higher blood sugars. Corticosteroid use. So if we have to use steroids on those moms, that's going to increase their blood sugar. So we always have to think about what could be another underlying cause if we're giving them the insulin and they're not eating too much. What could be another reason for that? So if you're looking at this for a mom, you want to look at two things. One is a mom with type 1. So here's your type 1, here's your type 2. So the first thing we're going to be dealing with are moms that are type 1. We're going to be doing insulin because they have to get that sugar under control. So that's what we're going to look at for our type 1s. Type 2s or gestational, we're going to look at diet. Diet's going to be our big thing because they're going to have to, watch what they're eating. They're going to have to stop eating those carbs. The doctor will kind of get them in with a dietitian to have them help them learn the healthy types of foods that they can eat that are also good for the baby and mom. So then you can see the next layer is very, very important too. So type 1s is going to be their diet, but it's going to be exercise too. So this is going to be a big one. But for these guys, insulin's going to be our next step in our exercise. So we want them to control it. We're going to try to control it with diet. If we can't control it with diet, they're probably going to have to be given some type of insulin. And then we're going to monitor those babies the whole entire time. So we're going to do biophysical profiles, kick counts, non-stress tests, all of those tests to make sure that our babies are staying okay, because we want a good outcome for our babies. So treatment, again, it's going to depend on what we're doing, but fetal surveillance, which I've already talked about that. Now, let's say we have a mom who is, I don't know, 37 weeks and, or 38 weeks, and we're getting ready to induce her. We got a big baby. Sometimes it's a really good idea. Sometimes the doctors will go ahead and do an amniocentesis, and they will just check that fetal lung maturity and make sure that we're mature. If not, they might want to keep it in there a little bit longer just to make sure we get those lungs mature, but we can't keep it too much longer because then our babies just keep getting bigger and bigger and bigger. So there's kind of like we have to decide which one's going to be the best. So when these moms get pregnant, it's not going to be as simple as a mom who has a normal pregnancy that progresses normally. These moms are going to require a lot more intense therapy. They're going to have to be at the doctor a lot more. They're going to have a lot more testing, a lot more lab work. They're going to have a endocrinologist that's going to be a part of their care because that's who's going to be probably prescribing all their insulin and their those types of things. A perinatologist is someone who's going to be taking care of mom and baby. And then a lot of times there will be a neonatologist that sometimes will be available once the baby's born to be able to deal with any type of hypoglycemic issues. Social workers, making sure that we can get those moms everything that they need. They may have to see a doctor in St. Louis or somewhere else if they live in a different, that would be for us. But if you lived in, a rural area outside Chicago, they may have to go into a city to find those physicians that are going to be able to care for their babies and themselves. Dietitians, all of that kind of stuff. Now, these are just all the complications that can occur from the diabetes. They're going to be way more prone to preeclampsia or hypertension. And you can see what is going to be coming there. So we're going to need to check these moms not only for their blood sugar every time they come to the doctor. We're going to check for ketones, but we're also going to be checking for protein. We're going to be checking their blood sugar, and we're going to be looking for edema. Again, the biggest edema that we want to look for is face and hands. Those are the ones that are going to be indicators of our hypertension. Okay, that's it. Thank you, guys.